of the Pediatric Allergy, Immunology, and Rheumatology unit in Shams University, Egypt. But first, I would like to thank the Scientific Committee of the ACID Congress for giving us a chance to present our work. As an introduction to my talk, I would like to give a brief background about the mevalonate kinase deficiency, which is a rare autoinflammatory syndrome caused by mutations in the mevalonate kinase gene. The disease includes a continuum of two phenotypes, what's formerly referred to as hyperimmunoglobulinemia D with periodic fever syndrome, now termed mevalonate kinase deficiency, and mevalonic aciduria. Patients with mevalonate kinase deficiency present with fever, gastrointestinal symptoms, lymphadenopathy, arthralgia, skin rash, and mucosal ulcers. Furthermore, patients with the more severe type mevalonic aciduria can also present with dysmorphic features, prenatal and postnatal growth retardation, as well as neurological and ocular involvement. So understanding the function of the mevalonate kinase enzyme, we have to get a closer look at the mevalonate pathway for cholesterol biosynthesis, where mevalonate kinase works on the mevalonic acid to produce the isoprenoid compounds as intermediate products, and then finally go through the cholesterol biosynthesis. These isoprenoid compounds are very essential for different cellular function, including electron transport, cell proliferation and differentiation, and protein synthesis. So the deficiency of this enzyme is classified according to the level of defect, where markedly reduced enzyme activity is found in patients with mevalonate kinase deficiency, reaching between 1.8 to 28% of the normal level, while almost absent enzyme activity is reported in patients with mevalonic aciduria. So going to the pro-inflammatory state found and characteristic in this disorder, it has recently been identified that cellular isoprenoid deficiency leads to the activation of monocytes, macrophages, RHO-A and RAC1 with subsequent interleukin-1 beta hypersecretion and pro-inflammatory cellular pyroptosis and apoptosis. In Eero fever registry, the most frequent combination of mevalonate kinase gene was that causing replacement of valine into isoleucine on protein and isoleucine to threonine heterozygosity, occurring in 22% of the patient, followed by homozygosity of the mutation causing replacement of valine to isoleucine in 12% of the patient, and combined heterozygosity for the two mutations had a significantly increased frequency of amyloidosis type AA. However, other rare mutations have been associated with more continuous course of the disease and more severe gastrointestinal and musculoskeletal involvement. So we aimed in our study to evaluate the relationship between the genotype and phenotype of mevalonate kinase deficiency patients. This was conducted at the Pediatric Allergy, Immunology, and Rheumatology unit. It was a retrospective study that included patients who presented with prolonged febrile attacks at very early age, and in whom a diagnosis of mevalonate kinase deficiency was highly suspected. They were genetically tested later on. There were 4 boys and 2 females. Their age at onset has a median of 3 months and ranging between 0.7 to 4 months. Their age at diagnosis has a median of 18 months and ranged between 0.7 to 60 months. They actually presented very late to our unit. Parental consanguinity was positive in 5 patients, and they were all Caucasians, 5 Egyptians, and 1 Syrian. So I would like to demonstrate the clinical characteristics of our studied patients. All patients have continuous course of the disease with exacerbation. They all have fatigue, malaise, and some weight loss that was prominent in the 2 female patients who had severe gastrointestinal involvement. Skin rash in form of urticarial vasculitis was found in all patients, while oral ulcers was present in 50% of the patients. All patients had arthralgia, arthritis, and hepatosplenomegaly and lymphadenopathy. Abdominal pain was the most frequent gastrointestinal involvement in 67% of these patients. So studying the association of mevalonate kinase gene specific mutations to certain clinical features of this disorder and outcome. We started with our first patients who presented at the age of 6 months, but his his age at the onset of his symptoms was at 23 days. His main clinical involvement was arthritis, hepatosplenomegaly, and lymphadenopathy. The detected gene mutation was that causing replacement of histidine into glutamine in protein. This patient had initial good response to anakinra, but shortly he had severe exacerbation ending with macrophage activation syndrome, and sadly he died. His sibling had the same presentation, same age at onset, his symptoms and same mutation, but he was fortunate enough to diagnose at presentation. And he received anakinra with a very good response. His response to anti-TNF was only partial. And anti-TNF was given in case of lack of availability of the anakinra. The patient achieved remission on anakinra and he is alive and doing well. Third patient had the same presentation. His age at the onset of his symptoms was 4 months. He presented to us at the age of 1 year. And his mevalonate kinase gene mutation was that causing replacement of the glycine into arginine on protein. Samely, he had very good response to anakinra with partial response to anti-TNF in case of lack of anakinra. He achieved remission on anakinra and he's alive and doing well. The fourth patient had her symptom at the age of 2 months, but presented to us at the age of 1 year with severe failure to thrive, arthritis, hepatosplenomegaly, lymphadenopathy, and some sort of Crohn's-like picture. She was found to have a mutation causing change of the arginine into stop codon protein. She had no response to anti-TNF and only partial response to anakinra. Sadly, she had severe exacerbation with macroactivation syndrome and she died. The fifth patient is a female as well, and she has similar yet very milder presentation to patient 4. Her age at the onset of symptoms, her age at the onset of her symptoms was 4 months. And she is the only patient who demonstrated increased immunoglobulin D. She presented to us at the age of 4 years. The genetic mutation was not done. This patient has a very good response to anakinra, and after stoppage of anakinra due to a lack of availability at some time, she was shifted to anti-TNF with a very good response, and she is the only patient who achieved remission on and was able to stop the treatment. She is alive and doing well. The sixth patient had onset of his symptoms at the age of 4 months as well. He had history of sibling deaths of similar condition of 4 siblings, and he had arthritis, abdominal pain, chronic diarrhea, hepatosplenomegaly, and lymphadenopathy. His genetic sequence revealed no mutation, and he had a very good response to anakinra. This patient presented to us at the age of 5 years, and he achieved only remission on anakinra. He did not respond whatsoever to anti-TNF or anti-IL-6. He's alive and doing well. So in conclusion, diagnosis of the studied patient was based mainly on the clinical features suggestive of mevalonate kinase deficiency. Measurements of immunoglobulin D is expensive and at the same time infrequently elevated. So we cannot rely on it for diagnosis of mevalonate kinase deficiency. Measurement of mevalonic acid during febrile episode should be implemented in suspected patients to have mevalonate kinase deficiency in the future. This might help early diagnosis and allow starting the target therapy. Studying the genotype of the patients and its association with the clinical spectrum of the disease will help to adjust the treatment protocol to avoid life-threatening complications and unfavorable outcome. I come to the end of my lecture, and I would like to acknowledge the team of the Pediatric Allergy, Immunology, and Rheumatology unit that was founded by our late mentor, Professor Yahya El-Ghoneimy, who is really missed. And special thanks to Professor Raif Jiha and Dr. Janet Cho and all the team for performing genetic sequencing for patient number 3 and number 4. And thank you so much.